This presentation will cover the use of transvaginal sonography in evaluating the endometrium and endometrial disorders. It will cover the technical factors, including scan technique and instrumentation to optimize imaging of the endometrium. I will cover the endometrium in premenopausal and perimenopausal women, as well as postmenopausal women, and I will discuss the sonographic findings in various endometrial disorders, such as hyperplasia and cancer. And I'll talk about the application of transvaginal sonography in evaluating women who are on hormone replacement therapy, and just mention the application of transvaginal sonography in evaluating the endometrium using sonohysterography. Basically, the use of transvaginal sonography in postmenopausal patients who have bleeding is to evaluate those patients that need endometrial biopsy and also patients that need sonohysterography and D&C, and of course to evaluate patients that are having bleeding in patients on a hormone replacement. And transvaginal and or transrectal sonography provides a means for guided biopsy of endometrial disorders. Basically, the technical aspects of providing excellent images of the endometrium focuses around understanding that the endometrium is an unusual and somewhat irregular geometry, and that we must use the probe and image the entire endometrium in different scan planes to assess its texture and integrity. We have to have focal areas that correspond to the level of the endometrium. The endometrium also is affected by a patient's weight. In fact, patients that are heavier have more thick endometrium, and certainly patients with fibroids may have the endometrium that is displaced by submucosal fibroids. I prefer doing the patient on a pelvic examination table to let their legs relax and use the non-transducer hand to move the uterus to some degree to optimize imaging of the endometrium. The endometrium is basically a specialized mucous membrane. It has both a functional layer, which is built up and shed in patients that are of childbearing age, and a basal layer, which is not shed. As you can see from this diagram, in the menstrual phase, the endometrium is irregular due to sloughing, usually the first 3 to 5 days of the cycle. After that, there's a gradual buildup of the endometrium, with the glandular elements still being rather small and the spiral vessels being rather small and confined to the functional layer. In the secretory phase, the endometrium thickens, the glandular elements become distended, and there is a ischemic phase in the last few days of the cycle where there's decreased flow to the endometrium, which predates sloughing. The graph on the bottom basically covers what is a typical bilayer thickness in the anterior-posterior plane in normal endometrium. As you can see, in the secretory phase, the endometrium can measure up to 12 millimeters, but typically measures between 6 and 8 millimeters during this phase. Now, I will be showing you the pictures of the endometrium, and I think it's important to realize that we can image the endometrium by observing the layers in the myometrium. The myometrium is made up of 3 layers. The inner myometrium is the more longitudinally oriented of these. The middle layer of the myometrium, which runs from the inner layer to the arcuate layer, is shown here, and then the outer myometrium corresponding to these areas in the drawing, the spiral layer, and the outer layer of myometrium. I mention these because you can use these to determine whether or not you have a complete evaluation of the endometrium. Here in the long axis, we can see the endometrium starting here at the cervical corporal junction, extending into the fundus, and we can measure the endometrium in the greatest anterior posterior plane. We have an outer hypoechoic area, which is the inner myometrium. We have the spiral layer, or the middle layer, followed by the outer layer of myometrium, and this is in the long plane. When we turn the transducer 90 degrees, we can see the endometrium as a linear interface, the inner myometrium, which is hypoechoic, the spiral layer, which is more echogenic, and then the outer layer of myometrium is very nicely shown here. When we turn the probe 90 degrees to that and image in the long axis plane, we can get a more transverse image of the endometrium as shown in this diagram. This is not the proper plane for measurement in the anterior posterior plane, since this represents the transverse dimension of the endometrium, and a lot of patients will have a uterus that is somewhat rotated. And we can see it makes a big difference in the measurement of the endometrium, whether you're measuring the transverse dimension as shown here in the same patient. We're rotating the probe and we're getting a 5 millimeter endometrium, which is much less than the transverse plane. So it's very important to be attuned to these details when you measure the endometrium. And this is another example of measuring in a retroflexed uterus the transverse dimension of the endometrium, which is not the same as the bilayer thickness. This is the endometrium in a patient who has a retroflexed uterus where the fundus is oriented toward this part of the screen. And you can see here that this is the correct measurement of the bilayer thickness of the endometrium. Now, there's about a 1.5 to 2 millimeter inter-observer variation in measurement of the endometrium. And I think this should be kept in mind when we say we have a 7 millimeter endometrium. That could be anywhere from 5 millimeters to 9 millimeters. Now, it's important to have the highest frequency probe that is focused in the area of the endometrium. This is two examples of probes. This is a tight curved array probe operating at a nominal frequency of 5 megahertz, whereas this is a higher frequency probe with a more compact footprint, as you can see here, and we would want to image the endometrium with that probe. And here visually is the difference between the older probe with a lower frequency showing an echogenic area in the endometrium. With the higher frequency probe, we can see in fact that what we have here are multiple small clots within the endometrium in a patient who had just undergone endometrial biopsy. This is another measurement error that is not uncommon, and that is including the inner myometrium in the measurement of the endometrium. As you can see here, this is the proper measurement. This is a measurement including the inner myometrium. As you can see in this patient, there's an apparent thickening of the endometrium, which was originally measured to be 22 millimeters, when in fact the endometrium is only about 9 millimeters, and what is happening is this submucosal fibroid is displacing the endometrium, making it look thick. Another variation one can see is the C-section scar can be rather prominent in some patients. As you can see here, this is not the endometrial interface.